All right, well, I make it 2 minutes past 10, so let's get started this morning. Welcome everyone to the Hepatitis Queensland and Cairns Sexual Health joint event, Bridging the Gap Forum, Viral Hepatitis Service Delivery in the Era of COVID-19. Oh, let's see if I can make the slides work. There we go. I'd like to begin this morning with an acknowledgement of country. So I acknowledge the traditional owners of country throughout Australia and recognise their continuing connection to land, waters and culture. Pay my respects to their elders past, present and emerging. I'd also like to acknowledge that in this National Reconciliation Week, that Aboriginal and Torres Strait Islander people are disproportionately impacted by viral hepatitis. So in response to the current COVID-19 pandemic, this 60-minute forum is a platform to hear about how organisations are rapidly innovating their service model to keep clients and staff safe while keeping long-term health outcomes in mind. We know that many of you have been focused on Queensland's response to COVID-19, but we also know that you recognise the importance of supporting and treating people with chronic diseases such as viral hepatitis during this time. The format of the forum this morning will be a 5-minute presentation from our 7 invited stakeholders, and then we'll have time for a moderated question and answer session from the audience at the end. The forum is being recorded, and I'd encourage you to keep your microphones on mute and your cameras on if your bandwidth will support that. Each speaker has been asked to speak for up to 5 minutes about what services or programs have been disrupted the most due to COVID-19. What strategies and innovative solutions have they implemented to address those disruptions? And what does the other side of COVID-19 look like for your service? I'll ask that you please hold any of your questions to the end when we should have ample time for a question and answer session. And you can also message the whole group or individuals using the chat function at the bottom of your screen. Is Raquel here? Can you speak to me if you're here, Raquel? I can't see her name on the list, so I might move us straight into our second speaker, and hopefully Raquel will join us a bit later on. So our second speaker is Amanda Cavasay from Quinn, where she works as a project officer. Amanda, if you can pop yourself off mute and take it away.
Great, thank you. Thanks Hepatitis Queensland and Cairns Sexual Health for the invitation to speak today. So I'm speaking on behalf of our team at Quinn, which includes our medical, clinical, counselling, harm reduction and peer workforce. So just on to the first slide, thanks Caitlin. So our major service disruptions during COVID-19. So we have a range of services: therapeutic, counselling, individual and groups, prison in reach, outreach to vulnerable communities, medical services provided through our Better Access Medical Clinic, needle syringe programs, and our Hepatitis C treatment management program. So all of our services have been adapted quite quickly from the daily. And are you okay, Caitlin?
Yeah, sorry, you just had a bit of cut out there. Could you just say, you started by saying all of your services at Quinn, and then we lost it a bit.
I might just turn off my video for my internet connection. Sorry about that.
No problem, no worries.
So all of our services adapted quite quickly from the middle of March. Any decisions were made through our emergency planning committee, which was led by our CEO and head of services. The goal for Quinn throughout the period has been to keep our clients and staff well and to keep our services open. So we're open from 9 till 7, Monday to Friday, and we've been able to do that throughout COVID-19. We implemented work from home duties, as I'm sure many services did, from mid-March, and that was really to ensure that we had minimal staff on site at all offices. Our therapeutic team moved to telephone support, and where possible, groups continued by video conference. Medical clinic moved to telehealth quite quickly, and clients presenting to the clinics face-to-face were triaged as per COVID-19 guidelines, and our OST services have continued. So regarding our Hep C and NSP services, we were able to modify our spaces in our NSPs to reflect physical distancing requirements. It required an enormous amount of new procedures, obviously regarding cash handling, environmental cleaning, and all at the same time we wanted to make sure that we maintained a friendly and approachable service. So regarding our Hep C, we work normally across 8 sites from Townsville to the Gold Coast, and again we move quite quickly to telehealth and where possible, providing that the client had the technology available through smartphones, we moved to video conferencing where the client agreed to do that. The biggest disruption really has been around the reality of people very rightly staying home. So the number of new clients in has slowed to our service, and the number of clients completing pathology as part of treatment workup and also our SVRs has also slowed. Our prison transition worker stopped in-reach to prisons in late March, however has continued to receive a number of referrals, and any medication transfers that they're doing have been relying on pharmacy to pharmacy transfers where possible. We also had our new Hep C support team recruited to in March, which was great timing. So we've used this time to orientate and upskill. However, we've not been able to get out and visit stakeholders to promote the service, which has definitely slowed our initial plans, but it has not in any way curbed our enthusiasm. So strategies and innovation solutions. I've touched on some of these already. The main focus for us has been adapting quite quickly to telehealth service model. We've also been very quickly adapting to using webinars and Zoom platforms for training purposes and modifying existing spaces, as I mentioned, so that services continue to open in a safe manner. And as I mentioned, all of these have been happening through the development of new procedures. Interestingly, the move for us to telehealth and video consults has improved our no-show rate at our clinics. And perhaps that's making us more flexible with people not having to catch public transport or travel to offices for an appointment, which may have been a good thing for our clients. We've adapted where possible to securely transferring pathology requests and scripts directly to service providers and pharmacies closest to where the client resides to avoid the initial very lengthy mail delivery delays, which meant that we had to look for some alternative solutions there. We've also increased our case conferencing amongst our teams to ensure that our clients don't get missed. Interestingly, we received some funding from the local PHN to conduct a FluVax outreach project. So we've been able to link our new Hep C peer staff into that project, which has been quite fortuitous because by default, we've managed to recruit some new clients into testing and treatment. And these are clients that we would not have otherwise seen in our existing clinics. So that in itself has provided us with an opportunity to think about how we can work differently over the next 12 months. So the other side of COVID-19 for us, we anticipate moving towards face-to-face service delivery again when Queensland moves to stage 2 easing of restrictions, which will be around at this stage, we're hoping mid-June. So obviously there's a lot of planning underway at the moment to ensure that we can do this and maintain staff and client health and wellbeing. We're very excited to move into point of care testing for our hepatitis C clinics, and we hope that this will overcome some of those barriers that we've faced in the last couple of months with pathology in particular. We'll have point of care tests in each of our NSPs and we're able to test people opportunistically and also capture people for SVR testing. For us, this will be a game changer and we're very excited to be able to implement it. It will change our model of service delivery, we think, for the better, and will allow us to expand our Hep C outreach clinics further afield and free up valuable clinician time. We're looking to keep telehealth as an option for our client group into the future by offering a dual modality at clinics. So where clients aren't able to present at a clinic, we would like to try to continue to offer telehealth for those clients. We will look to do more flexible outreach with learnings from our participation in the FluVax outreach clinic that I mentioned, and obviously with that, the implementation of point of care testing. But overall, for us, I guess this has been an opportunity for us to learn how we can continue to meet our clients' needs just in a very different way. We've learnt a lot and I'm incredibly proud of our team at Quinn. It feels like we're getting to the other side or whatever this new normal looks like, and we're looking forward to getting out on the road again and seeing our clients. That's it for me.
Wonderful. Thank you very much for sharing all of that with us, Amanda. It's really fascinating to hear from different services and with the breadth of services that Quinn provides as well. Really interesting to hear how you've had some success in adapting your service model. So thank you very much.
Thanks.
Our next speaker is Dr. James O'Byrne, who is a Professor of Hepatology at the University of the Sunshine Coast and a Consultant Hepatologist at Sunshine Coast University Hospital. James, take it away.
Oh, morning everybody, and thanks to Hepatitis Queensland and Cairns Sexual Health for putting this together, because I think it's really important and we can learn from each other. The title of my couple of slides really is hepatology in the time of COVID-19, rather than just purely on viral hepatitis, because certainly our hepatitis service is one of the moving parts in quite a big sort of machine, and I think the impact on our whole service has impacted on hepatitis services and vice versa. So if I just tell you what our service looks like, because in the next slide, because actually we've done a couple of things in the past year or so that have, I guess, helped us adapt to this COVID situation. So the main hepatology service is based at Sunshine Coast University Hospital, and we have 3 general hepatology clinics a week, which cover liver cancer, cirrhosis, viral hepatitis, fatty liver, etc. We see about 120 patients a week, probably about 25 of those new and the rest follow up. We have a busy inpatient service, usually of decompensated chronic liver disease, and it was interesting to see how that changed. And we have 2 CNCs who run a sort of 5-day-a-week nurse helpline. Now, SCU serves a massive sort of area going all the way up to Kalula Coast, and because there's no hepatology service in Wide Bay, we developed a couple of years ago this thing called the Hepatology Partnership, where we have Kerin Param, who's a very experienced CNC, goes out and sees clients and does FibroScans locally to the place, to where they live, and we facilitate treatment via the GP with an MDT. You can see that picture at the bottom. So that's been running for quite a while and has been quite effective, and originally was designed to sort of take FibroScan technology out into the community. To serve some of our other patients who need to come to the hospital but can't quite travel all the way to SCU, we have a general hepatology clinic at Nambour, and that was impacted quite significantly. And we used to have an in-reach service into the prison with FibroScan, but I think through more good luck than anything else, with the Wide Bay Hospital Health Service and the prison have got 2 fantastic nurse practitioners in place at the moment. And they run pretty much the whole of the viral hepatitis treatment service in Maryborough Correctional Centre. But myself and Kerin support that with a weekly video conference MDT for difficult cases, retreatment, and etc. So we were already using quite a bit of telehealth and community sort of engagement and access. But if you just go to the next slide to see how things impacted, well, very, very quickly, we had to completely change the way that we offered our whole hepatology service. So all face-to-face appointments were initially converted to phone appointments. The interesting thing was that you found that, I mean, I find it very difficult to take a history and come up with a treatment plan with a client over the telephone. Video conferencing is okay, but it's not as good as seeing somebody face-to-face. But nonetheless, that's what we had to do, because patients either didn't want to come to the hospital, or we felt it wasn't safe for them to do so. This was in the very early stages of the pandemic. Plus, our CNCs were redeployed to run fever clinics, so our service was sort of almost decimated, and we had to sort of think on our feet quite a bit. We were conscious that at the same time, what we saw was a massive reduction in the inpatient admissions for decompensated chronic liver disease. So we knew that these people were out there, and we're now in the recovery phase. We're now beginning to see these patients flooding into hospital. And we've got, you know, a number of patients on the ward now with mainly alcohol-related liver disease who've just suffered from self-neglect and too much alcohol at the time during the lockdown. The Hepatology Partnership, obviously it wasn't feasible for Kerin to be wandering around Wide Bay and Sunshine Coast with a mobile FibroScanner. We couldn't get patients to come to sort of the community clinics, but thankfully we'd already done a piece of work looking at the utility of FIB4 to predict the absence of cirrhosis in our population in the Sunshine Coast and Wide Bay. And so it was very easy to flip over to essentially just run the whole thing via phone based on the local blood tests and FIB4. And Keren's been super at sending out prescriptions, faxing pharmacies, and generally the patients, interestingly, prefer it over the phone somehow. She does have, she's managed to persuade some clients to download a video sort of conferencing app called Infinity or Pexip to their phones, and that's helped with some people. And certainly in Wide Bay, the failure to attend has massively reduced, whereas we've found around the hospital, around general hepatology, that our FTA rate in terms of not being able to contact people has actually gone up. And I suspect that's because many people, myself included, if they get a call from an unrecognised number, they don't answer it. Luckily, there are a few centres in private providers across the Sunshine Coast and Wide Bay who are able to offer shear wave elastography. So if we are worried that somebody might have cirrhosis and we want to get them onto treatment, we can signpost them to the shear wave elastography services, and most of them bulk bill. I mentioned that we've got this rise in decompensated chronic liver disease, and the prison MDT support we continued. So the prison prescribing wasn't impacted at all, which is great. Now, out of this, we've realised that the way to deliver hepatology care, both for viral hepatitis C and B and general hepatology across Wide Bay and further north around Bundaberg, is through a dedicated telehealth service. So through, if you will, this pandemic has prompted us to galvanise our telehealth service and make it a bit more robust. So now we've got some real organisation around it, and that's going to be something that will be in the legacy of the post-pandemic era. We could just go to the next slide. So where we're at now is 50% of the hepatology partnership for hepatitis C are phone appointments. The need for FibroScan has gone down massively because I was using FIB4 in a younger, more recent infection crowd. What we have noticed, though, is a marked reduction in new referrals into that hepatology partnership. Now, that hepatology partnership program depends on referrals from GPs. And I think what's happening is that because the GPs aren't doing as many face-to-face appointments, there's less opportunity for opportunistic screening. And so our number of new referrals to hepatitis C has gone down. Many of our, or 25 of our, in this recovery era, 25% of our general hepatology work is now via telephone, and that's very acceptable to the patients. And we've developed, as I said, this dedicated telehealth clinic, which is run out of Nambour, which is going to be once a week for patients from Wide Bay, and the prison continues as it is. So we have made some changes. I think the fact that we'd already had an eye on developing a structure whereby people didn't have to travel to a central point of care for hepatitis C treatment has helped us. I think the biggest worries for us as a global service at the moment are if you will, the second wave of neglected disease, be it liver cancer, decompensated chronic liver disease that we're now seeing post-lockdown, and the fact that I think we're getting maybe 1, maybe 2 new referrals of hepatitis C from Sunshine Coast per week now, where we used to be getting 15.
Thank you very much, James. I'm going to say that you're all finished there.
Yeah.
That's a really fascinating look at how you've adapted services and how you've been able to take some pre-pandemic learning and what sounds like make some real improvements to access in the local area post-pandemic. So thank you very much for that.
Thank you. We hope so anyway.
I'm excited for it. Raquel, I think that you've joined us now. Can you speak to me?
Yep.
There you are. Hello.
Hello. Sorry for my lateness.
No, that's okay. Would you be comfortable going next?
Yeah, sure.
Yeah, let me just I'll just go back. I don't have any slides for you, but I've got a little thing that's got your name on it.
Yes,
So thank you very much, Raquel. Raquel is a nurse
That's okay.
practitioner at the Prison Health Services in West Moreton Hospital and Health Service. Take it away.
Thank you. So just so I'm not too sure who's online and who's going to be listening to this. So if you're aware of what we do, so at West Moreton Prison Health Services, we basically look after Brisbane Correctional Centre, Wolston Correctional Centre, Brisbane Women's Correctional Centre and Barallan Correctional Centre. And in about 2 weeks' time, it'll be Arthur Gorrie Correctional Centre as well. But so we actually have a nurse practitioner in a nurse navigator position for bloodborne viruses, Chris. But he actually has the portfolio for all 4 of our prisons for bloodborne viruses and predominantly looks after that whole portfolio. So he will visit a centre 1 day a week and he will independently manage and treat all our Hep Cs that are non-cirrhotic, basically, our clear-cut, non-cirrhotic, young, fit, healthy hepatitis C patients. Now with the new changes to the PBS on the 1st of April, nurse practitioners can write the S100 script. So we've been able to now do that completely independently. He liaises with Graham at the park in regards to any cirrhotic patients or hepatitis B patients. They have a fortnightly teleconference, which we always did pre-COVID. And so that's still going. So as far as COVID changes, the way we delivered care didn't change because we never... Our tertiary hospital consultations always happened by the majority of the time by telehealth, even with all our normal, even our liver failure patients, our cirrhotic patients, most of those appointments already occurred via teleconference with the PA, and then there was not a huge hindrance if the patient had to go to the PA because they needed to physically see them. In the beginning of the COVID crisis, corrections had a rule that if you left the centre, you came back and isolated for 14 days. So in that respect, it hindered us a little bit because we had, say, a couple of patients who should have been scheduled for an ultrasound who didn't want to go and have their ultrasound done. So, you know, as part of surveillance or whatnot. So that kind of pushed their treatment back a little bit because they did not want to come back and have to be isolated. That's now changed. They don't have to isolate now when they come back. But that was probably one of the major changes that we had. And one of the other changes we had would have been to prisoners, although in each centre we could still see prisoners as nurse practitioners and as nurses. Chris could still see prisoners as part of my role. What did reduce was the amount of prisoners we could see because they had reduced the amount of prisoners being housed or being waiting in an area. So for example, in our medical centre, we were only allowed to have 5 prisoners come down and wait in our waiting room at any one time, which hindered us a little bit if you've got 3 nurse practitioners, a doctor and a dentist and prison mental health and the dietitian and the nursing clinic all wanting to see patients at the same time. I'm not too sure where we're all seeing those patients, but we couldn't see them in the health centre or it was reduced. So the amount of people that we were able to see in regards to hepatitis and essentially start on treatment or follow up just decreased a little bit, so maybe pushed our waiting times out a little bit. Post-COVID, well, not much is going to change because we didn't really change much to start with. post, I suppose, now it's not really post-COVID per se, COVID related, but given the fact that our nurse practitioners can now prescribe, we're actually seeing that we can actually treat patients quite quicker, because I can see a patient as part of my primary health portfolio, and instead of having to refer them to Chris after I do bloods for him to organise a script and whatnot, I could do it all. So, you know, we're actually seeing people a little more, if that makes sense.
Thank you, Caitlin. In the interest of my NBN not buffering, I might keep myself without my video as well. And so, as Caitlin said, my name's Sammy Stewart, and last month I started back at Ascham as the National Viral Hepatitis Program Manager. I am managing all of our hepatitis B and hepatitis C work across the country, but I'll be based in our Brisbane office at Fortitude Valley. And also acknowledging the traditional custodians of the land, which for me here in Ashgrove is the Turrbal people, and acknowledging, just as Caitlin said, that we're in the middle of National Reconciliation Week. So thinking about Asham's service delivery during the time of COVID-19, it's of course really impacted our face-to-face professional development and our training, as well as our face-to-face conferences. So for the Australasian Viral Hepatitis Conference, which was scheduled from the 6th to 18th of August this year in Brisbane, we're going to be pushing that conference back to 2021. It will still be in Brisbane and it will be face-to-face, but the date is still TBC. For our Australasian HIV/AIDS and Sexual Health Conference, it's really excitingly going to be a virtual conference, which will be later this year. And again, the date is TBC. In Queensland specifically, our Queensland Prisons Forum will be postponed to early 2021 and will still remain face-to-face, as well as the Deadly Sex Congress, which will be in mid 2021. In terms of business as usual, we are working really hard on our updated Asham branding and making sure that is sitting across our entire portfolio of resources. Monitoring and evaluation is still going on, and we're really closely monitoring the learning outcomes of our online training and comparing it to our face-to-face training to make sure we're having the same outcomes, even with a different modality of delivery. Our policy and advocacy work is still trucking along really nicely, and it was really great to hear about the nurse S100, the nurse practitioner S100 prescriber accreditation working out there in the world. And our reconciliation action plan, which we started at Asham back in March, is tracking along really nicely. And Asham are quite well placed to connect and work remotely, with so many of us working from home pre-pandemic, and with staff based in Brisbane, the Gold Coast, Sydney, and in Melbourne. So on to the next slide. Thinking about the innovation and strategies and solutions that we have brought to the table. For those on the call who aren't aware, we have a COVID-19 task force, which was established on the 20th of March. Provide healthcare workers in the bloodborne virus and STI health sectors with timely and high quality evidence guidance on various scientific, clinical, treatment and prevention aspects of the pandemic, especially in relation to the patient populations that are living with or at high risk of bloodborne viruses or sexually transmissible infections. Since we started on the 20th of March, we've got 90 members, currently chaired by released 8 bulletins with a variety of writing pieces included in each of those bulletins. We've delivered 8 webinars, and we've had 22,000 page views to our COVID-19 website, which is listed there on the slide if you want to take a look. 9 news stories, 3 radio interviews, and we're just at the brainstorming stage now to figure out how our task force work will continue as the pandemic continues to shift and change. So please feel free to reach out to us via the email address on that slide if there's particular guidance you want for your work or things that we should be giving particular attention to. Our course conversion working group has been working tirelessly to make sure our face-to-face training is properly adapted to online. We've been utilising Zoom, recording sessions, engaging speakers with lived experience to talk via Zoom, and embedding this content into learning pathways on our online learning management system. And in terms of connecting as a team, it's been really fun to have musical bingo and trivia and afternoon tea breaks, and even a virtual pub to keep us connected and engaged as people as well as professionals. So the last slide, in terms of what is on the other side for us after COVID-19. Again, I think just using all the lessons that we've learnt about how we can connect and collaborate remotely, and focusing on the strengths and the resilience that we've all shown as a team during the pandemic. New ways of delivering workforce development. I think it's going to be really interesting to see what this means for our future engagement and future contracts as we get such high response rates to our online learning. And most importantly, I think for the organisation as well as me personally, is making sure that our colleagues in regional, remote and rural areas are also having access to the same education opportunities as those who are living in city centres, and using webinars and our online learning management system seems to be breaking down those barriers, which is really great. We've got a really big focus on our learning management system on our website and on our social media at the moment, making sure that we're engaging with our members, communities and sectors in the best way possible. Using online programs to increase relationship development. So for example, our communities practice for hepatitis C and hepatitis B online. And it's been really interesting to hear all of the different people on this presentation so far talk about telehealth, because telehealth is going to be a really big focus for us and our workforce development, as well as our policy and advocacy work moving forward. I think just as other speakers have said, the changes that have happened pre-pandemic as well as during the pandemic are here to stay. And I think that should have a really important role to support our workforce as they continue to engage with telehealth, and also work alongside our community organisations to make sure that those particular issues in terms of access and the social justice implications of relying on technology for connecting with our patients. It's going to be really interesting and wonderful to see how this work shapes ASHM and the entire sector moving forward. Just very quickly, because I forgot to mention it, we have a hepatitis B S100 prescriber training program coming up in July, the date of which is TBC, and that is open to anyone and everyone in Queensland. So please get in contact with me if you want to be put on the marketing list. Thanks, Caitlin.
Good morning, everyone. I'd like to begin by acknowledging the traditional owners and the many Guri tribes on their lands on which we deliver our services. And I'd also like to pay my respects to the elders past, present and emerging. First slide. Well, I think we were asked to answer 3 questions. I think the first one was about which services and programs have been disrupted. And I think I can safely say that this has been a complete system disruptor, COVID-19. And I'd looked up the definition of a system disruptor. It's basically an event that prevents a service system or process continuing as usual. And I think I can say that all our systems and processes have been revamped, and they've all been unable to continue in their usual manner. And by and large, that's been a really good thing. So, you know, we've seen huge opportunities for innovation, and some of the obstacles and barriers that were really standing in the way of us progressing have actually just evaporated. It's amazing how they've kind of disappeared when some of them have been there for a long time. Next slide, please. So in terms of how we've responded as an organisation and as a network, so we have 20 community controlled health services across southeast Queensland, and we operate as a network. We've got 5 different organisations in our network, but we've had a regional response to the pandemic. And I suppose there's 5 components really to that. There's a community focus, and we've really ramped up our ability to connect with community and to receive feedback from community through a massive increase in the amount of social media that we've had output, and and also obviously receiving feedback in that way. So our conference room has been turned into a recording studio, and we've had daily Facebook output. So we've already had our Deadly Choices branding, but the Deadly Choices Facebook page has been extremely active. We've had, as I said, daily output on there. We've had live podcasts, and in fact, there's one going on at the moment. It's an all morning live podcast for World No Tobacco Day. We've also had 98.9 FM, which is the country music Aboriginal radio for Brisbane, and we've had daily input into programming on 98.9. So using those existing platforms and existing brands and connections has been one of the strategies for reconnecting or connecting more strongly with community. We've also had quite a number of staff who've been redeployed, so we haven't been able to continue some of our programs. Obviously, the Deadly Choices programs in schools was one of them, and those workers have been redeployed really to doing other community contact and connections, so keeping in touch with people. We've got the aged care emergency relief service. We're delivering lots of meals. So I think there was 100 meals taken out to people in hostels, motel rooms around Brisbane. So people in temporary accommodation. Each day that's happening. Leadership, I suppose, is the second thing that's probably worth mentioning. So keep calm and stay deadly is the mantra really for the whole organisation, and certainly the leadership has really stepped up and provided very strong messaging. So there's a weekly briefing now for all staff. So we've got about 600 staff in IUE, and larger numbers across the network, probably around 1,000 staff across our network. There have been daily updates and from team leaders, and we've also had the policy team. So we've got a team of people who are really waiting for new announcements from the government, seeing what impacts that might have on our organisation, but also a good ear to the ground for opportunities to gain new investment and new opportunities to provide services for clients. So the other thing that the leadership's been doing is their COVID collectibles. So we've been collecting up great ideas, the things that we don't want to give up after the COVID pandemic, so that we can hang on to the really good and innovative ideas that have emerged. Teamwork is kind of essential really. Staff working able to be redeployed, people working very flexibly. So we've had dental assistants who've been working in fever clinics as concierge staff. We've had people delivering meals who would normally be sitting behind desks and working on spreadsheets. So basically we've had a huge amount of innovation. We've also opened four new respiratory assessment clinics across southeast Queensland. Normally opening a clinic probably is a 3-month process, and we managed to open 4 in a month. We've had can you just go back to the systems approach? So systems, really, we've developed a regional toolkit which enables all staff to really adapt what they do. So it's using the principles that we've learned, and the IUE toolkit is actually available on the NACCHO website if you wanted to go and have a look at it. And obviously there's a strong organisational culture underpinning everything. And one of the great things that we've seen is the emergence of new leaders. So people stepping up into roles that they're not necessarily being prepared for or knew they would be able to do, and really making a massive difference. So last slide, please. So the last slide, I thought I would concentrate on hepatitis as that's what the meeting is really around. So hepatitis B, we've got this, we've developed in conjunction with Hepatitis Queensland, an audit tool which interrogates GP software to produce a register of clients, or potentially, or at least give you data around your clients with hepatitis B and how well they're being followed up. And we've used that to produce registers of hepatitis B clients, and we've been going through our registers and making sure that clients are up to date with their follow-up. In terms of hepatitis C, we've been using the opportunity to engage with clients. Perhaps we feel like we've picked a lot of the low-hanging fruit with hepatitis C, and a lot of our hard-to-reach clients are now in much more stable situations. So, for instance, we've had 26 of our long-term rough sleepers in our network who've actually gone into permanent housing. We've got lots of other people who are now in temporary accommodation, and we're hoping that will be their transition off the streets, off homelessness into more permanent accommodation. I guess the challenges in the medium term are probably around that digital divide. So we've heard a lot about telehealth today, and we've got to recognise a lot of people don't have access to telehealth. And we're just setting up new systems and processes to make sure that people aren't getting left behind in that situation. So being able to deliver our services over telehealth for those that require them. And then I suppose the other thing about we've got this roadmap that the states developed. We're also developing our own roadmap out of COVID, but also recognising that roads go in two directions, and we may have a second wave, we may have a third wave, and so we might have to go back down the road again, as well as looking forward to the roadmap out. And then in the long term, I think, capturing all those COVID collectibles, all the innovations that we want to hang on to, all the silos that have been broken down across the health system. We're really looking forward to working across those, and also integrating our services in a much more meaningful way. So thinking about health and social health in particular, preparing for that mental health pandemic that we're also expecting to arrive at some point. In fact, we're already starting to see lots more mental health presentations, domestic violence, and probably all those other things that are going to accompany high levels of unemployment. And moving into the space really where we're delivering integrated services, so looking at housing, education, employment, and health as a whole, really.
Thanks, Caitlin. I'll start first and then bring Rhonda in. Rhonda's done a lot of the work with these slides, by the way. So next slide, thanks. So our service is a broad sexual health service. We do a variety of things, and including viral hepatitis. Next slide. We had a lot of changes, as everyone else has outlined. We normally see 300 or so patients a week through our clinic, and that halved to about 150. We saw a lot of people face-to-face, but we saw a lot of people sort of interacted with people over the phone a lot, or via other messaging and virtual platforms. We put in place a COVID symptom check at the front door. We're fortunate to have a nice breezeway outside, which is covered. So we had nurses there, and now more recently, dental nurses from the dental clinic have been doing that job. Waiting rooms cordoned off a bit. It's not very welcoming now. Front desk has got a barrier, a bit more difficult for NSP clients to get a pack. Consultations have been phone-based a lot, as I said, and we've tried to do rapid sexually transmitted infection screens without having to see the person. And of course, out the back, our service is also running a drive-through fever clinic where we're seeing 70 or 80 people a day and swabbing them for COVID. So as well as doing sexual health, we're also doing COVID checks. Next slide, thanks. What about for Hep C? Well, the NSP services haven't changed all that much, although NSP presentations have decreased. But as a result, the NSP services are giving more packs to each person, or to those who want them. So people aren't out and about as much. We did have a Hep C Health Promotion Week, and that's been postponed. We were doing some work with the Kirby Institute for a study. And we had a film project that was supposed to do some filming as well, make a great little short film, but that was also postponed. So that's been a bit of an issue. Next slide. Fortunately, we haven't really seen a decrease in the number of people coming in for Hep C treatment. We accept GP referrals, so that really hasn't changed. But we have walk-in and referrals from the needle and syringe program and other places around town. So we don't seem to have seen a reduction there. We've got an incentive program for Hep C, and that's continued to attract clients, and Rhonda will talk about that next. We've given out some hand sanitizer for our most marginalised clients, a bit of an incentive to engage with our service and to remind them. We've established a fortnightly outreach Hep C testing clinic so people don't have to come into our service. So this is done off-site. We've been fortunate enough to have a medical student with us, and she was there for 9 weeks and did a chart audit of our Hep C care. So we've done a few things we wouldn't have been able to do before because we've been a bit quieter. And we're continuing our work up at the correctional centre up at Lotus Glen in Mareeba. And the liver clinic and ourselves go up there still monthly, so we're still seeing prisoners face to face up there, and there doesn't seem to have been a drop off in the requirement for Hep C treatment, and we're continuing to treat all that we can up there. Next slide. I think it's Rhonda's turn now. Yes, I'll let Rhonda chime in here.
Thanks, Darren. So just before kind of COVID broke out, we had started an incentive program for Hep C testing that was funded through the EC project. And it's just a little project. We got $5,000 to give people $10 at each stage of testing and treatment. And we had been planning to really promote that quite heavily, but we pulled back on that because it has an element of peer referral, and people loved that and they really wanted the money, and it didn't feel safe for our peers to be coming in with their mates. But actually, word had already gotten around about these $10, and it's difficult times and people have really wanted the money. So people have still just kept coming in dribs and drabs. So we're not seeing a lot of people because we've already treated a lot of people, but we are seeing about one person a week or getting a referral. We've started to have a partnership with Hospital in the Home, and seen a few more mental health clients. Since the government benefits have increased, we've also actually bumped up our incentives and decided we'll be giving people $20 at each stage of testing and treatment. We just want to make sure we keep people coming in the door, and I think in the end that incentive has really actually been very helpful for people at the moment. Next slide, please, Caitlin. So on the upside, we have a community reference group chat, the Cairns Hepatitis Action Team, and the team have all been kind of stuck at home with not as much to do, and so they have actually had more energy and time to meet and gather, and we've planned quite a few activities for World Hepatitis Day this year. Their strength is around kind of resilience-based story gathering. So they're planning to interview community members and find out how COVID-19 has affected them. And we'll take a resilience-based kind of approach to that. We don't want to leave anybody feeling, you know, sad or upset by their storytelling, but they're quite good at that. So I'm really looking forward to that project kind of coming up in July. And because of the grant we got from Hepatitis Queensland, we've also been able to negotiate with our Aboriginal radio station around doing some ads for Hep B and Hep C, which is really important because we've also recently had increased numbers of Hep C in Indigenous clients at the local prison, and we're just wanting to have more conversations with the community about that and raise a bit of awareness. And the next slide, please. And this is our last slide. So, you know, I love hearing how all of the other services today have been resilient and found the opportunities. But, you know, there is, I think, for all of us, a low-lying level of stress. And in our service, you know, we've kind of split in half and become a fever clinic as well as a sexual health clinic. And it hasn't been easy, and people have been so wonderful. So we decided, you know, for everybody's mental health, we'd bring puppies to work. and that was wonderful. We've had to have the carpets cleaned as well due to that, but you know, it's just, I think, lovely to hear people doing their innovative things like a virtual pub. Well, yeah, we did puppies at work, and as you can see, it was a roaring success. And that's all from us. Thanks.
Hi, thanks very much, Caitlin. Just want to firstly start off and say thanks again to Hepatitis Queensland and Cairns Sexual Health for setting up this awesome opportunity. So I guess from our side of things, our bloodborne virus, from our hepatitis side, we've actually been quite lucky and unscathed. I guess because as our service is quite large and expansive land-wise, we've actually, majority of our work was already either telehealth or very minimal face-to-face contact. We also service the corrections facility currently. So we actually had appointments increase by 35% comparing this year to last year. And surprisingly, new referrals were actually up 375% for April 2020 versus April 2019. So which is probably due to the fact that we are so large and expansive, and face-to-face isn't really a barrier for us. One thing we had to do because of the COVID was to cease face-to-face unless it was extremely required, and telehealth was also ceased, so we didn't have to expose patients travelling to their local hospital and then possibly meeting with anything in the hospital, I guess you could say. The biggest impact would definitely have to be telehealth within corrections, in the sense that we were actually decreasing our telehealth appointments because limited movement was required in the facility. So that, I guess that's sort of something we had to sacrifice in a way. I guess next slide, please. So to overcome this, like I said, we changed all our face-to-face and telehealth appointments. We've swapped over to actual phone consults. They're actually it actually improved with our timing on our afternoon clinics. We noticed that we weren't running over as much because we weren't having like the technical difficulties associated with telehealth and video calls dropping out and things like that. It was usually on a phone line, and a lot of the time we actually sent out letters to our patients and we'd call them mobile directly, so they knew what time we were going to call and they were there. I guess some of the downfalls of that would be being rural, how sometimes you might have poor reception. Oh, hang on a minute, let me just go outside, crackle, crackle, and then you'd sort of get a better service when they went outside. Another thing that we found beneficial was having three-way chats when we required interpreter services. So that was actually beneficial in the sense that you're not getting the patient in the room and then you're both crowding over this little tiny speakerphone, which can be hard to hear at the best of times. So that was beneficial in that sense. Next slide, please. In the future, we hope to return telehealth and be more flexible if clients are wanting to actually have phone consults rather than travelling to their nearest hospital, which out west could be a couple of hours drive just for a 20-minute appointment. But again, that would all be based on the clients, what they would prefer. I guess similar to Raquel, we didn't really see a decrease in any services. If anything, we saw an actual increase and a decrease in the rates of FTAs. One thing though might be a barrier for us changing to phone consults would be that some of the smaller hospitals might be activity-based funding, so they might lose funding if we switch from that video conference style to them just doing a phone call at home.
Just been appreciating the dog staff day with spaniels and bulldogs, but no questions relevant.
Thanks. Yeah, happy to take any questions if anyone has anything.
I was just wondering about the telehealth models and whether there's been any thought about, like combining some of the services and, the access that we've now got to case conferencing via telehealth. We can do joint consultations between primary care and secondary care. You can have a specialist telehealth consult at one end, and you can have an Aboriginal health worker or a nurse sitting at the other end, and both ends of the service can bill for Medicare. There's lots of different options for telehealth apart from just the one-to-one with the client. So I'd wondered whether anybody had been experimenting with those options.
Has anyone had experience with those at all?
We're just in the beginning of our telehealth service with Wide Bay, and you're right. The reason why we wanted to explore that is because we can have a clinician up in Wide Bay and a clinician down on the Sunshine Coast, and even though they're separate health services, both will benefit in terms of the billing. And just, you know, in terms of what Nicole was saying, I think that whilst the clients really love the convenience of telephone, they don't have to leave their house and it's all very easy. The billing around that, I think, is a little bit difficult. I know we have these MBS codes that we're supposed to bill for, but then we've been told that we have to specifically consent the patient to be Medicare billed for the phone call before we even get into the chat, and that, as a doctor, that feels a bit weird to me. So I tend not to bother doing it. So I'm probably making my service financially unsustainable. But yeah, no, I think there are lots of options. I was discussing with the guys from HEP Queensland about a sort of, you know, reinvigorating a Project Echo type thing, where instead of educating GPs about treatment of viral hepatitis, actually getting them into an online environment where they can actually discuss real cases and we can give treatment advice, and that leads then to a prescription. But I think that's been sort of tried before and wasn't very successful, I believe, according to Caitlin.
Yeah, we trialled a telehealth model with sleep apnea clients, where the specialist is on the end of the line, the client and the care coordinator are in the GP clinic, and the care coordinator is able to download all the data from the client's machines, and there's also a GP on hand if a physical examination might be needed, or the care coordinator is able to collect observations from the client. So that's another model that could work. And we've even had cases where the client has failed to attend. So if you get appropriate consent beforehand, you can actually convert the thing into a case conference, and so it's not a wasted effort. And you know, the case conference can turn into that sort of collaborative way of working, where you might end up with a prescription actually occurring even though the specialist hasn't seen the client face to face, or on the tele video link. So I think there is lots of different options, and it's kind of yeah, that ability to be flexible, I think, is testing us all.
So Raquel here. We originally started, when we first started treating hepatitis patients in our prisons 3 years ago, we started with the ECHO model, and it worked really, really well. So the nurse practitioners in each centre, and then our bloodborne virus nurse practitioner would do all the workup, all the physical assessment, all the blood work. And once a fortnight, we would have the case conference by video with our hepatologist specialist at the PA. We would discuss all the cases. He would make recommendations or agree with our treatment options. And then at that stage, he had to write our script. But from then we've progressed, of course, but we're still using that type of model where for all our complicated patients, cirrhotic patients, alcoholic liver disease patients, all those other patients, and it works well.
No, I think it works well in a prison environment, and that's sort of what we're doing with Alana and Kim and Maryborough. I just get a feeling there's got to be a way of getting it to work for more remote or rural areas, really, but probably it's very, very difficult in a constrained, you know, clinic time to do that with just one individual GP at a time, because somebody was mentioning about the technical problems with telehealth. I mean, I find that a telehealth appointment takes usually probably twice as long as a face-to-face appointment.
Thanks, everyone. That's a really interesting discussion. Are there anyone else with a question or a comment?
Hi, Rhonda. It's Lana here from
Queensland. I just wanted to say what an amazing job all these clinicians are doing in such a difficult space, not only dealing with, you know, the complexities of managing patients with Hep B and C, but throwing in all of the extra considerations around COVID. And I just think from my perspective, sitting back here listening to all of this today, it's been a really great show of how everybody has been responding. So well done to all of you.